Thank you so much. So good afternoon, everyone, and thank you for joining us today for our webinar on assessing organizational ability to support client self-management. Next slide, please. This is the second webinar in a series of 3 focused on self-management support. The first webinar in the series was developed by the Centers for Integrated Health Solutions and was on peer-led interventions to increase activation for self-management of chronic physical and behavioral health conditions. Today's webinar is going to be interactive with 45 minutes of presenter-led discussion, followed by 15 minutes of presenter and participant discussions. There will be an opportunity for questions and answers at the end of the webinar, so please submit your questions to us using the Q&A function. Also, a copy of the slides and a recording of the presentation will be made available at resourcesforintegratedcare.com. Next slide, please. This webinar is developed by the Lewin Group in collaboration with the SAMHSA HRSA Center for Integrated Health Solutions. It's hosted by the Medicare-Medicaid Coordination Office, Resources for Integrated Care, or RIC. Next slide, please. The Centers for Medicare and Medicaid Services is accredited by the International Association for Continuing Education and Training. CMS complies with the ANSI IACET standard, which is recognized internationally as a standard of excellence in instructional practices. As a result of the accreditation, the Centers for Medicare and Medicaid Services is authorized to issue continuing education credit for this webinar. Next slide, please. To earn continuing education credit, complete the post-test through the Centers for Medicare and Medicaid Services Learning Management System and score 80% or higher by midnight on August 7th, 2017. More information is available again on our website, resourcesforintegratedcare.com. Next slide. The Medicare-Medicaid Coordination Office in the Centers for Medicare and Medicaid Services ensures that beneficiaries enrolled in Medicare and Medicaid have access to seamless, high-quality health care that includes the full range of covered services in both programs. To support providers in their efforts to deliver more integrated, coordinated care to Medicare and Medicaid enrollees, MMCO is developing technical assistance and actionable tools based on successful interventions and care models such as this webinar. Next slide, please. Next slide. So I'd like to take a moment to introduce our speakers for today. My name is Alexis Esteman, and I am a Federal Health and Human Services Consultant with the Lewin Group. I lead efforts to support behavioral health organizations and providers in delivering behavioral health and other health services under the technical assistance to support providers in providing care to Medicare Medicaid enrollees contract with the Medicare Medicaid Coordination Office. We'll also be hearing from Larry Davidson. Larry Davidson is a professor of psychiatry and director of the Program for Recovery and Community Health of the School of Medicine at Yale University. His research has focused on processes of recovery and self-care in serious mental illnesses and addictions, the development and evaluation of innovative recovery-oriented practices, including peer-delivered recovery supports, and designing and evaluating policies to promote the transformation of behavioral health systems to the provision of recovery-oriented, person-centered, and culturally responsive care. In addition to being a recipient of psychiatric care, Dr. Davidson has produced over 375 publications. Kristen Davis joins us from Thresholds. Dr. Davis earned her doctorate in health communication, and after teaching at colleges and universities in the Chicago area, is now the Director of Evaluation at Thresholds. She has written peer-reviewed papers, spoke at numerous conferences, and conducted in-person trainings on behavioral health topics. Our last presenter is Larry Fricks. Larry Fricks is the director of the Appalachian Consulting Group and deputy director of the SAMHSA HRSA Center for Integrated Health Solutions. For 13 years, he served as Georgia's director of the Office of Consumer Relations and Recovery in the Division of Mental Health, Developmental Disabilities, and Addictive Diseases. A founder of the Georgia Mental Health Consumer Network and Georgia's Peer Specialist Training and Certification, He has a journalism degree from the University of Georgia and has won numerous journalism awards. Next slide, please. Just to provide a brief overview of our presentation today, we'll start out with a few poll questions, which we'll get to in a moment. Larry Davidson is going to introduce self-management support, and I will review Rick's self-management support organizational assessment tool. Kristen Davis will then discuss how her organization used the SMS OAT to assess capacity for self-management support, and Larry Fricks will discuss what a culture of recovery looks like and values for whole health self-management. We'll then move into a period of questions and answers. So at this time, we can move into our first poll question. For those on the line, if you could just take a moment and answer the question, which of the following best describes your professional area? We'll keep this open for just a few more seconds. And I think we can go ahead and close the poll and take a look at the results. Great. So it looks like we have a number of folks across the board. We have some folks from behavioral health, health plan management staff, policy research, social work, and healthcare administration, as well as a number of clinicians. So thank you so much for joining us. We can go into the next poll now. And please let us know what your primary role is within your organization. We'll keep this open just another second to allow folks to enter their responses. All right, I think we can go ahead and close the poll and take a look at the results. It looks like we have a number of care coordinators and care managers on today, administrators, clinicians, consumer advocates, educators. So again, thank you all for joining. And we'll move into the next poll at this time. This will be our last poll today. You could just let us know in what setting you work. We can just leave this open another second. At this time, we can move to the results. We have a number of individuals representing managed care organizations, federally qualified health centers, those in the ambulatory care setting, behavioral health care organizations, and community-based organizations. We can go to the next slide. I just wanted to quickly review our learning objectives for today, and then I'll hand it off to Larry Davidson for our first presentation. After this webinar, you will be able to define the importance of self-management support in serving clients managing mental illness or substance use conditions, recognize your organization's ability to support self-management activities using the self-management support organizational assessment tool, and also identify best practices for expanding the capacity to integrate support for self-management. So we could go to the next slide. At this time, I'm going to hand off the presentation to Dr. Larry Davidson. Larry, please go ahead.
Thank you, and thank you for joining us today for this webinar. If I could have the next slide, please. You'll see here at the top that the Institute of Medicine defines self-management as the tasks that individuals must undertake to live well with one or more chronic conditions. Ordinarily, we think of that in the context of chronic diseases like diabetes or asthma or hypertension. It's only been fairly recently that we've begun to consider that it's possible to do this, to live well with a serious mental illness or substance use disorder. For many decades prior, These were illnesses that we didn't really think of as illnesses per se, and even if we did think of them as illnesses, we thought of them as chronic, debilitating, and even progressive. They weren't things that we thought people could live a good life with. But over the last 30 years with the recovery movement, we've now come to understand that you can live well in the face of an ongoing mental illness or substance use disorder, and that it's very possible and important for persons with behavioral health conditions to learn how to do so, just like persons with chronic physical conditions. Next slide, please. So what we've learned from the recovery movement is that many people diagnosed with a serious mental illness or substance use disorder will be able to recover fully over time. The statistics on different illnesses vary, but in each case there are many examples of people being able to recover fully from even disorders like schizophrenia or addiction. However, not everyone is going to recover fully, and what the recovery movement has focused equally on is the possibility of learning to live a full life in the face of an ongoing condition, something that we're coming to call personal recovery as compared to clinical recovery. It's essential in the pursuit of personal recovery to learn the self-management skills that are possible given the condition that the person has, and that has become a central focus for behavioral health care. This means we've shifted, or are making a shift in paradigms in behavioral health, from viewing treatment as something that expert providers do to clients who are passive recipients of care or at best are supposed to follow the instructions of providers, to people who need to take a more active and collaborative role in their own recovery and in their individual lives. And organizations need to make this paradigm shift as well as care providers. Next slide, please. So how does one go about supporting self-management? What does it involve? You start by eliciting and understanding the person's own perspective on their situation, including what they understand about the illness that they have or that we think they have or that we're trying to educate them about. But we need to understand first where they're coming from so we can meet them where they're at, so to speak. Then we engage them in a collaborative decision-making process where they can articulate their needs, preferences, and goals, and we can situate the treatment and education self-management process in the context of those personal strengths and where the person's trying to get to in their day-to-day lives. This leads to activating the person to learn and exercise the self-care skills that we try to teach them. Sounds like the first webinar in this series focused squarely on this process of activation. It's become a very important part of the process to understand that people need encouragement, they need role modeling, they need lots of things in order to start to believe that they can manage these conditions, because they, like most of us, were originally thought of these things as sort of derailments from life rather than as something that one can learn to master in the context of one's everyday life. So activation involves a significant amount of work in getting people to believe that it's possible and that they have the wherewithal to do so. This involves focusing on things like self-efficacy and locus of control, helping people have hope that it's possible to live a better life and that they can play an important role in doing so. Then comes a process of mobilizing the natural supports in the person's life, typically family members, friends, other staff who are part of the multidisciplinary team, who can encourage and reinforce the use of these self-care skills on a day-to-day basis. And finally, in the spirit of seeing the person, the patient, the client, as a collaborative partner in the process, we elicit their feedback on how we can improve the acceptability, quality, and effectiveness of the care we offer. So I'm going to go to the next slide and turn this back to Alexis.
Thank you so much, Larry. I'm going to take some time now to walk through the Self-Management Support Organizational Assessment Tool, or the SMS OAT. Self-management has been demonstrated to increase individual satisfaction with healthcare, reduce the cost of care, and improve health outcomes for persons with a variety of chronic health conditions. Self-management is especially applicable to individuals with serious mental illness and to those with substance abuse conditions. Persons with serious mental illness or substance use conditions can use self-management skills to manage their behavioral and physical conditions, maintain their overall health, and maximize their quality of life. Next slide, please. To give a bit of background, the Lewin Group developed the tool in collaboration with CMS, along with the input of subject matter experts in consumer-centered care, self-management support, and also care coordination. The tool is derived from the experience of behavioral health clinicians, primary clinicians, and individuals with expertise in implementing self-management support. Further, the tool is built upon the foundation that supporting self-management involves a shift away from that more traditional model of care to one that is client-centric and supports shared decision-making. To facilitate the change means staff and organizations must structure and deliver care in ways that honor individuals' perspectives on their health care, treatment, and relationships with providers. This might also mean the adoption of new organizational processes to teach individuals the skills to manage their conditions and health over time and to collaborate with their healthcare providers to make decisions about their care. Self-management support also involves actively engaging a client's natural supports who can play a positive but non-professional role in recovery. Within any organization, this is likely to involve changing organizational cultures and setting new role expectations and service priorities. Behavioral health organizations can anticipate needing to innovate, acquire external support, dedicate time and resources, and commit to affect change and achieve this vision of person-centered and integrated care. Next slide, please. The goal of the tool is to help administrators, providers, or other service delivery staff in behavioral health and primary care organizations serving individuals with serious mental illness or substance use conditions. Ultimately, the tool intends to raise awareness of the features of client interactions and care processes consistent with self-management support, provide a blueprint or a roadmap to assess self-management support activities, and also highlight examples of ways that organizations can expand the capacity to integrate self-management support. Next slide, please. Our tool is broken into three main sections. The first section is focused on self-management support foundations, which includes three subsections. The first is client activation. Supporting clients to take active roles in their own care is essential to their recovery and increases care integration and coordination to meet their needs and goals. This support includes offering a range of options that facilitate meaningful choices by clients, as well as access to care and medical records. The second subsection is self-management support and care planning. Care planning and self-management support helps the care team, clients, and also their natural supports focus on interventions to manage symptoms while supporting clients in pursuing their self-identified goals. While it is typically the client who works with one staff member in particular, such as the primary clinician, nurse, social worker, or peer specialist, to develop the plan, the entire care team should be available for the planning meeting so that short-term objectives in the respective roles of each person involved are clear. The last subsection is supporting self-management with care teams. Clients and their natural supports benefit from services that range from medical care and home health services to supported housing, supported education or employment, and also peer support. A care or recovery team can best provide the range of services and often includes providers from different disciplines and settings, clients, and natural supports. The care team may also partner with outside organizations and can help clients and their supports coordinate the range of medical care and other services to meet their goals. Ongoing communication and collaboration among the members of this team, outside of periodic and more formal care planning discussions, can provide essential cohesion and avoid care that is not aligned with client goals. The second section of the tool is on monitoring self-management support activities. Ongoing monitoring is needed to ensure that your organization's staff or care teams continue to meet client needs and provide the necessary follow-up to help clients achieve and maintain their health. Collecting and assessing feedback from persons with behavioral health and substance abuse conditions, as well as their natural supports, improves the quality and responsiveness of care. Next slide, please. The OAT itself is a self-assessment tool, which is available online through an interactive form, a downloadable PDF, and also an interactive Excel tally score sheet. You can save your answers to review with your staff and coworkers, either by downloading a PDF of your responses in the online version of the tool or by saving your completed Excel file. And this can serve as a reference for your organization to consider potential areas of opportunity for improvement or focus. Next slide, please. Our team recommends that you ask at least 2 staff to review the elements of self-management support in sections 1 and 2 of our tool independently with the following instructions in mind. We recommend that you consider the prior 3-month period of care delivery and the clients you or your care team served when answering the questions. You should choose 1 response for each question, and it's important to remember that there is no right or wrong answer. Just make your best guess. The tool is intended to facilitate a team discussion about your organization's self-management services. On the right of the screen, you'll see a screen grab of the tool itself. Each section includes introductory language regarding that section's topic and also a set of self-assessment questions. We can move into that in a little bit more detail. So you can move to the next slide. To break down what elements of the tool look like and how they're scored, we can go through an example. The first item is, do staff and providers communicate with clients in a manner that promotes and maintains dignity and respect? The questions followed with a bit of a description as well as some examples of best practices. In this case, an example is to offer private places to discuss care concerns or schedule appointments. Next slide. The question then prompts you to consider a few different factors. How often does this occur? Are there policies in place and staff trainings available? Does the organization consider client feedback? Your answers to these 3 questions will determine your overall score for the element. Next slide. In this case, we just provided an example of someone that might have answered this question. A person that answers sometimes, never, and yes would get a total score of 2 for this particular item. And then you can also select whether this is a priority for your organization. Your scores for each element are then added up for sections 1 and 2 of the organizational assessment tool. Next slide. For the first section, if you score an 81 to 125, your organization has a strong foundation for self-management support. A 41 to 80 indicates that your organization has some of the necessary foundational elements for self-management support, and a score of 40 or less means that your organization needs to build a foundation for self-management support. You might want to consider the overall importance of self-management to the needs of your clients and how self-management may fit with your organizational priorities and procedures. For the second section, the max score you can get is a 35, indicating that your organization has a strong foundation of procedures to monitor self-management support activities. If you score a 13 to 23, this means that you have some foundational elements in place, and a score of 12 or less means that there are opportunities to improve or create procedures to support activity monitoring. You can take these results and use them to inform conversations with your organization about opportunities for improvement and how best to move forward. The SMS OAT provides examples of strategies organizations can take to improve different elements of self-management support delivery. Next slide, please. The last section of the tool includes other resources to implement self-management support services for individuals with serious mental illness and other chronic conditions. These include resources both developed by the Resources for Integrated Care team, as well as external resources, some of which we will introduce toward the end of this webinar. Next slide, please. And you can find the OAT at the link on the screen, along with several client handouts in our Action Plan Selection Guide, which will be explored in our follow-up webinar scheduled for next Wednesday, July 26th. Next slide, please. At this time, I'm going to turn the presentation over to Dr. Davis from Thresholds to tell us a bit how her team was able to administer the OAT to improve workflow processes. Kristen, if you want to go ahead.
Sure. Thanks, Alexis. Next slide. Before I talk about our process of using the tool and our outcomes, I'll briefly introduce Thresholds and provide the context in which we first used the tool. Thresholds is a large mental health and substance use agency in Chicago and 7 counties in Illinois, providing ongoing comprehensive supports to 5,000 consumers or members, which is what we call the folks who receive services from us a year. Now we touch via our mobile assessment units and our crisis intervention teams another 10,000 a year, but we see on a regular basis 5,000. We provide this regular support via 120 clinical teams and via our 3 integrated healthcare FQHC partners. Thresholds teams are comprised of social workers, psychiatric rehabilitation staff, peer staff, supported employment and education staff, often a nurse, an RN, and then a part-time psychiatrist. The support ranges from traditional case management support to medication monitoring, to supported housing, supported education and employment, to peer support, and of course, illness self-management support. Thresholds used thus far the SMS OAT tool as preparatory to a pilot initiative designed to reduce unplanned inpatient use by a small group of our consumers who have the most complex social and health needs. The pilot involves stratifying our consumers on just 4 of our teams based on their past ER and hospital use. We identified our highest users, which was about 5% of those consumers. And then we provided our pilot teams with relevant clinical and social determinant data in the form of an interactive dashboard targeting this high-risk group. Now, because Thresholds is so large, we wanted to start the initiative on a small scale and determine how useful the interactive dashboard report was in driving care, as well as what clinical practices made the most difference in helping members reduce unplanned use of inpatient services. So today, what I'd like to do is just provide a brief description of the role that the tool played in this pilot and what we learned from using it. Next slide, please. Okay, our process. Before we asked the 4 teams to work with our high need or their high need members, consumers differently and reallocate resources, we assessed the team's illness management or illness self-management support capacity, as we knew this type of activity would be a key component to reducing unplanned inpatient use. Excessive reliance on inpatient services is really a good proxy for members or consumers who are not managing their illnesses as well as they could. So after having introduced the project to the teams, we sent the tool to the 4 team leaders, to the quality of staff who is dedicated to those teams, to the program directors over the teams, and then one last higher up person, the vice president who oversaw the programs for those teams. Each of these staff scored the tool on their own. An evaluation staff then met with this group in person a couple of weeks later, and we facilitated the comparing of scores and identifying areas of shared understanding and disagreement. And it provided an opportunity for people to ask questions of each other, of course, and to discuss in a little bit more detail some of the items on the tool. Based on the results from this meeting, we drew up a provisional plan to prepare for the pilot. Now, it's important to say we ended up using the tool not only to assess our capacity to do illness management support, but also really to structure a conversation about what illness self-management support looks like from the perspective of those staff on the ground, given their unique workflow and what their needs and barriers are. Next slide, please. So what did we learn about our capacity? What did the tool tell us? Well, a few things. Overall, I think the project team scored themselves highly on the first subscale of the Self-Management Support Foundation, activating clients to engage in self-management, which, as Alexa mentioned, includes items like do staff communicate with clients in ways that promote dignity and respect, and are consumers involved in care planning, etc. Staff assessed capacity less favorably on a few items on the second Self-Management Foundation subscale, supporting self-management with care teams. In particular, visit preparation and follow-up on self-management support visits were identified as areas for improvement. The group agreed on a change to workflow as a result. And really, in some ways, this change to workflow is the first step. I think we're going to do some more process analysis to see what else we might do. But initially, what the teams have done is set aside time in a weekly strengths-based meeting to prepare for upcoming visits and share follow-up from previous visits for this group of high-need consumers. It also this meeting allows for, I think, a clear definition of roles of who's going to do what and when. Next slide, please. Okay, in terms of self-management and care planning, the project team realized during the scoring meeting that they could leverage our existing FQHC partnerships which really are marked by good care coordination and data sharing. Staff used the interactive dashboard to identify any high-need consumer or member who wasn't linked to one of our integrated care partners and really just took advantage of what is a teachable moment by talking to consumers about the benefits of good care coordination with our partners, but also about the importance of regular primary care. So in short, staff encouraged our consumers who weren't linked to one of our FQHC integrated care partners to go to them for their primary care needs. Next slide, please. Finally, and as for the second part of the tool, the monitoring self-management support and the interactive dashboard report itself, we realized that teams didn't feel comfortable entirely using the interactive dashboard report without some training and support. So we expanded the role of the quality improvement consultant to support the teams in using the dashboards, helping them identify care gaps, understand what we might do to fill them, and at the same time to collaborate with the teams to address any particularly difficult clinical issues. The QI staff also ensured a consistent focus on the self-management support practices. Next slide. So that is just a quick shot of what the interactive dashboard looks like. There's a pretty detailed description of the consumer in the box at the top, and I think what you're seeing now are some data on, the ER admissions and the hospital admissions broken out separately with a total on the far left. Next slide, please. So what overall lessons did we learn in using the tool? Well, one, let me just say that we will scale up. We're going to use the tool with other teams as we begin to use this kind of population health approach to identify and work differently with some of our folks who are not managing their illness as well. But I would also say that the tool, and I think as I mentioned before, really is a great way to start a structured conversation about illness self-management support, as well as a formal means to assess organizational capacity. I think illness self-management support is just a key activity when you begin to think about what's going to make a difference in terms of value-based care. The SMS OAT also showed us that staff welcome support in being able to prioritize, and that prioritization is a little bit tricky with the day-to-day work that they're involved in. So now I'm going to pass it over to Larry.
Thank you, and welcome all. Next slide, please. I think before we talk about recovery, we got to think about how big the impact and stigma is and discrimination. Rosalynn Carter, former First Lady of the United States, who has a mental health program, she says that it's still our biggest challenge. So, even with all the, improvements we've made, I think there's still, it's just something you've got to consider when you're looking at recovery. Some of the things that you could see when you go into a recovery culture, training and supporting peers to share their recovery story. our recovery story is one of our most important tools for connection and building a sense of trust. And so it's very important that we be trained on how to tell our recovery story. There's times when we tell that story and we spend too much time on the illness side. We don't have succinct points to make that gives a real impact. Like briefly describing your situation when you were having the most difficult time, and what helped you move from where you were to where you are now. What did you do? What did others do? What have you had to do to overcome to get where you are today? And then what are some of the strengths and skills that support your recovery? Those sort of questions help us really organize our recovery story. And so, if you see that going on, and you see the support and also the skills for it, and you get a sense that there's an understanding of how important the recovery story is and how it differentiates us from non-peer staff. And then focus on the strengths of an individual rather than the illness. I experienced this. I'm recovered from bipolar illness and also addiction. And I just experienced over and over again that when somebody became aware of my diagnosis, the behavior changed toward me, and they started just seeing me through that diagnosis. This is a real issue, too, for peers in integrated care. We're hearing stories that when peers go to see a primary care doctor and they see a diagnosis of schizophrenia or bipolar illness, that there's often a behavior change. And, all of a sudden, some of the symptoms, they say, well, I wonder if that could be related to our illness. So I think this is really important because, once again, the stigma and discrimination tends to have people focus on our illness. And then ensuring the overriding theme in everything is recovery. One of my favorite stories comes out of Michigan. There's a behavioral health program there that when you're in the lobby, there's a continuous loop of people telling their recovery story. So even before you walk in to see someone for treatment, you're being reminded of recovery and that all of us have recovery, and you're hearing these stories. So I think that sort of recovery theme in everything is important. And then promoting peer-led groups. You look at AA that was founded in 1935, and one of its pillars is that people in recovery lead those groups. And so, if I go into a program and I see non-peer staff leading the groups, and I question then and there, why aren't you having people's lived experience run those groups? And then promoting meaningful employment. I think employment is treatment. I know that sounds strange, but so many of us can relate to, we were experiencing some recovery, but when we got meaningful work, that just it just really added to our recovery. It gave us a sense of meaning and purpose. So, and I got a real lesson in this. In Georgia, we founded the Georgia Mental Health Consumer Network about 27 years ago. And we founded the conference with the main focus being on the attendees deciding what their top priority was. And almost every year it was employment. And so people were saying, I really don't need more time with my psychiatrist. I really don't need different meds. What I need is what a sense of meaning and purpose employment brings to me. So we, quite frankly, it was that top priority of employment, like Georgia invested in Medicaid billable peer support services, if we saw it as a possibility for people to get jobs. So, next slide, please. A goal that the individual owns is a foundation to recovery. And I hear people say, Larry Davidson, he just won't follow his treatment plan. And so if Larry owned it, if it was something that was built around person-centered planning, then he'd be more likely to participate. Ownership is key. And also understanding the personal benefit of reaching the goal and ensuring everyone has input into program development and evaluation. If you're in a program and it's obvious that the activities and what's going on there has the input from people that use the services, you're going to see a much higher level of excitement and involvement. And then bringing in program graduates to tell their success stories. It's just always uplifts me. I had been hospitalized 3 times in the mid-'80s, and I'd really given up. There's a lot of losses often associated with mental illnesses. There's loss of your jobs. My marriage fell apart. Loss of self-esteem, loss of a sense that my life could ever return to, a sense of fulfillment. And it was peers that changed that. I went to a meeting of the Depression and Bipolar Support Alliance, and having people share their success stories was a big factor. So in a program, bringing in people to share their stories, is a big factor for hope. It's a big activator of self-management. And then employ the significant workforce of peer providers. There's just so much research out there, and Larry Davidson's done a lot of it. That the lived experience and the connection and the trust from a peer, is there's mounting evidence that it may be the most important thing in activating self-management. So, if you see that and you see a workforce of peer providers, that program is investing in recovery agents and then engaging in whole health activity. Recovery is mind-body. For so long, people focused on just from the neck up. And what we know is it's the whole person you've got to look at in recovery. And so we're big on this whole concept of whole health and promoting the whole person. Next slide, please. And then promoting trauma-informed services. For years, people would not talk about trauma. They said it would re-traumatize us. And it's really been the people, the lived experience of trauma who have demanded that change. And so if you see that, that's being addressed, then you've got a program that is more tuned in to what's going on in people's lives. And then training consumers to write their own progress notes. There's no reason we can't write our own notes. Why does a clinician have to write our notes? We can be trained to do that, and then we have more ownership of it. And then educating staff and consumers on the definition and dynamics of recovery. You know, people don't know what recovery is, and I think it's worth investing in staff and consumers, evaluating, looking at it, talking about it, saying this is and this is not, and then teaching skills for problem solving. Most peers have never been taught skills to problem solve, and if you're going to self-manage, you need a skill to do that. And so, when we train peer specialists, we include a problem-solving approach that it lets you step outside of the problem and get more objective. And then, there's steps that you can take to really get a hold of what the problem clearly is. A clearly stated problem is most of the success. And lots of times people don't know how to clearly state that problem. And then teaching skills for combating negative self-talk. Negative self-talk it just undermines recovery. Somebody, if I have a negative self-image, you can come up to me and say 9 positive things. But if you say one that's not so positive, I'm going to reach out and grab that one because that matches up with my self-image. And so, because of stigma and discrimination, negative self-talk can really be an issue. I mean, everybody has negative thoughts and engages in negative self-talk. But that's not the problem. The problem is when it spirals downward and people end up defining themselves in absolute permanent negative language. And we teach skills on how to deal with that. Next slide, please. So at the Center for Integrated Health Solutions, we came up with a set of values for whole health self-management. Now, some of these, are closely related to recovery, but what we're trying to do is have people see recovery as a form of whole health, looking at the whole person. So the first one is for whole health, all services support whole health, mind and body. And then hope, activating and sustaining hope for whole health is the expectation for all individuals served. And then strength-based, services and supports focus on individual strengths and potential for whole health. And peer support. Peer support is integral to all whole health planning, services, and ongoing support. Trauma-informed care. Services are trauma-informed, understanding, recognizing, and responding to the role of traumatic life events, experiences, and effects on individual whole health. In person-centered goals, individuals set whole health goals as a result of extensive person-centered planning that focus on their strengths, support, skills, values, culture, and preferences. And then shared decision-making. It's just so important because there's a real power differential, between let's just say a psychiatrist and someone, in recovery. A lot of that, once again, goes back to stigma discrimination. A lot of it goes back to the belief that can you ever trust our thoughts, especially if we've experienced psychosis. And so, we teach a thing called shared decision-making so that it becomes a partnership. The doctor or the nurse may be an expert on symptoms and, on medications. But we have to be an expert on self-management. Now, what we decide to do is, if that's what's going to happen if we decide what we're going to do. So shared decision-making, healthcare providers build partnerships with individuals receiving services, make informed treatment decisions together. And then self-management competencies. You have to develop skills, knowledge, and supports to promote whole health self-management. And then resiliency. Evidence-based resiliency factors that promote whole health are a foundation of services and supports. And we're big now on resiliency factors because, in my own recovery, restful sleep was the key. When I learned from Dr. Fred Goodwin, that used to run National Institute of Mental Health, and he wrote the book Manic Depressive. He told me that if I could manage my sleep, I was much more likely to not have a manic episode. So it's been the bedrock in my recovery. And so, in our work, in our trainings, we introduce these resiliency factors. And interestingly enough, is mounting evidence that a strong support network may be the most important health factor in a person's life that trumps everything else. So paying more attention to resiliency, we're kind of looking at secondary and tertiary prevention. And, so it's very important to really understand what helps you be resilient and practice that. And then community resources and supports. Services promote community support, including family, friends, housing, employment, education, and recreation. So that wraps up the my slides. We do have some resources. We have a link to our peer providers on our CHS website. And we have the SAMHSA Wellness Initiative. And we have Whole Health Action Management, WHAM. That's something I'm involved with training. And then I really like this toolkit that came out of California, Meaningful Roles for Peer Providers in Integrated Healthcare. And then I always like to mention RAP, Mary Ann Copeland's work, excuse me. It's just been such a foundation for this whole concept of self-management. So thank you.
You can move to the next slide. Thanks so much, Larry. At this time, we can go into our session for some questions and answers. If you could move to the next slide, please. Great, thank you. So if you have any questions for our presenters today, please feel free to submit them through the question and answer function on the webinar platform. We have a few questions from folks that we'll take at this time. The first question that came through today was, what is a natural support? And I'm happy to answer that question since we talked about natural supports when we introduced the self-management support organizational assessment tool. A natural support is someone who cares about the client and that the client can ask for support. This might include a family member, a friend, a neighbor, a coworker, employer, a sponsor, a coach, or maybe even your landlord. And we have another question that came through our chat function that I'd like to field to Kristen, if you're on the line. The question that came through is, how do you work around the issue of clients losing their eligibility for disability benefits if they obtain too much income from employment opportunities that are helping with their mental health? Kristen, I'll field this question to you or any of our other presenters on the line.
Sure. So that's a great question. We, of course, battle that issue regularly, and I'm probably not the best person to answer all the different ways we try to work with it. There are benefits counselors, the Thresholds, who are staff dedicated to just benefit counseling, and I know that they will work with members who are working and have exceeded the limit and are in danger of losing their benefits. But unfortunately, that's probably the best answer I'm able to give. I don't know if anyone else has a response.
Well, I will just second that. I think individual benefits counseling is the most useful because there are a number of different federal programs that have been developed in the last 15 years to try to ease the transition from disability to employment, and the benefits counselors are in the best position to know who's eligible for what kind of program. It's understood that getting off disability is the most significant disincentive to working, losing your entitlements. So the federal government has been experimenting with different ways of trying to ease that transition, and people who are knowledgeable about that are the ones who need to be in the room with the client.
Great, thank you. I'll go to another question here. Kristen, this is another question for you. Is your organization planning to re-administer the SMS OAT following some of the next steps that you had discussed?
Yes, in fact, we are. We are going to begin to roll out the what I'm referring to as this population health approach or initiative focusing on improving our illness management self-support capacity. And so to do that, we will, preparatory to any other team that comes online using the interactive dashboard and working with our members who are in and out of the hospital or ER more frequently, we will do the tool. Feedback from the teams, which I didn't explicitly say in my slides, was positive. They not only appreciated the opportunity just to sit down and take the time out of their day to talk about some of these issues, but really felt like some of the things that we put in place are working and making their lives a little bit easier. So that's a long answer, and the short answer is yes, we plan to use it as we take a stepwise approach to bringing other programs online.
Great, thanks so much, Kristen. I have another question that came through. And Larry Fricks, I'll throw this to you, and then Larry Davidson, if you could maybe chime in with any other answers you might have. The question is there a resource for teaching skills for problem solving and combating negative self-talk? Any resources that you all would recommend?
Well, what we teach in peer specialist training is called Catch It, Check It, Change It. And it's sort of the catch it is, you catch it early on. This involves knowing when thoughts are moving from fact to story. Negative self-talk, it usually starts with a fact, but somehow our negative image moves it over to a story that's not necessarily true. And then check it against what is actually happening. And you stick with the facts, and then change it to more appropriately reflect reality. So we teach that to peer specialists, catch it, check it, change it.
Thank you. And Larry Davidson, I don't know if you have anything else to add regarding resources for negative self-talk. I think that would take us through to the end of our 60-minute webinar. Okay, well, I think we can go ahead and close out at this time. If you can go to the next slide, please. Thank you all so much for joining us today. If you could please complete our brief evaluation of the webinar so that we can continue to deliver high-quality presentations. If you have any questions for us, please email them to ric@lewin.com. Any questions you submit over the Q&A function, we'll also make sure that we work with our presenters to answer them and get you a response. So thank you again.